So today my topic is heterogeneity of mechanism contributing to neurodevelopmental morbidities in children born with congenital heart defects. So to understand this topic, we need to go more than 50 years ago, when the brain examination were mainly post-mortem examination or post-surgical examination of the most severe subtype of CHD. And the observation were that there is the main injury were hemorrhagic and ischemic injuries. So when the first paper from Neuberger and colleagues showed that for the first time that cognitive outcome, cognitive performance was reduced in children with TGA, the guilty part was clearly identified. And I want to precise one thing about this illustration, that any resemblance to existing character would be purely coincidental. So let's move on. Obviously, we can put all the responsibilities on the shoulders of our surgeon. Sure, we know that there is some injuries after surgery, but as Joanna said, that now we know that there is also some brain injuries prior to any interventions. And what is most interesting is that the spectrum of brain injuries differ in the preoperative and postoperative periods. And this preoperative brain injury must look like to the injury that we can see in premature babies, as you can see in the left of the screen. That's why there is a parallelism made by Volpe and colleague between the encephalopathy of CHD and the encephalopathy of premature babies. And he defined it as a complex amalgam of developmental disturbances affecting particularly white matter. And when you understand and know this, so the question after this is, sure, if there is some injury at birth, there is potential injury before birth. And as you can see, with really simple marker like the size of the brain, the brain volume, you can see that some cyanotic CHD have a smaller brain size than the control. And we know now that this process begins really early during pregnancy, in the middle of the second trimester. And now we know that the brain volume in the fetus is associated with neurodevelopmental outcome after 2 years of age. And it is not just a question of size, obviously. And as Joanna said, the size is just the representation of the more of injury of microstructure. We know that there is an imbalance between neurogenesis and apoptosis in these children. So we know now that cyanotic CHD have more cell neuronal death in the fetus period. So clearly, neurodevelopmental disorders are the consequences of just one or two factors. But there is a huge variation with so many factors, and this don't start in the postoperative period like we used to think. But they probably start much earlier during fetal life, and maybe even during cardiac and brain morphogenesis. And there is also another degree of variation really important to take into account, is the weight of each covariable in the model. Because in the end, if our goal is to make interventions and improve outcome, we need to go to understand how much influence each factor really has. So to illustrate this two dimension of variation, let's talk about ApoE. ApoE is a regulator of cholesterol metabolism. We know that this protein is really important and play a huge role in the neurological recovery after ischemia or hemorrhagic or traumatic brain injury. We also know that ApoE subtype is associated with early Alzheimer's dementia. So some studies suggest that some variant of ApoE will be at risk for neurodevelopmental disorder in CHD, and actually that hypothesis was correct. And it was confirmed in two studies, one in 2009 and the other in 2014 by Gainer's team. But unfortunately, or fortunately, ApoE only explain 1% of the variation in the model. So that's why if we want to create real-life intervention, we can just ask if this variable associated with neurodevelopmental disorders, but we also have to ask how much does it really matter in the big pictures. When we talk about INET factor like ApoE, we want to obviously go further and ask about genetics. And that brings us the usual question between nature or nurture, INET versus acquired. I'm not going to talk about genetic today because we are lucky to have Dr. Sarah Morton with us today, coming from Boston, and she will talk about this topic much better than I could. So stop spoiling, we just need to wait a little bit more. Now, let's talk about influence of the hard effect on brain. We are still during pregnancy period, and two main underlying mechanisms are intermittent, depending on subtype of CHD. Cerebral hypoxia and cerebral hypoperfusion, and it's pretty easy to understand. When you compare a fetus waist transposition of great artery here in the middle of the screen to a normal fetus, you can see in the normal fetus that oxygen blood coming from the umbilical vein going to the right atrium, left ventricle, and aorta give inadequate oxygen to brain. For TGA, right ventricle, then aorta give an adequate blood flow, but with really low oxygen level. When there's cerebral hypoperfusion, which happen more in defect with the left-sided obstruction, and you have sometimes like HLHS who have actually the both mechanism, as you can see in the right of the screen. And this is not just a theory. Now we can observe in vivo brain hypoxia using fetal MRI, especially with T2 star sequences, which help estimate oxygenation level in brain tissues. And as you can look at the graph, it's pretty clear. Tissue oxygenation is significantly lower in fetus with TGA or HLHS than control. And actually, we can also observe the direct effect of hypoxia on brain thanks to piglet animal models. In this study, we create a chronic brain hypoxia in piglet. We can see the effect with less development in periventricular corticals area, as you can see, hypoxia here and control here. You can see that there is a lower neuron density when you compare, and you can also see that there is an underdevelopment of dendritic cells. What is recently demonstrated is that this is not just a question of the brain and CHD interplay, but there is a third player in the game. This third player is the placenta. And we know now that there is a prevalent abnormal placenta in some cyanotic CHD. And so this abnormal placenta with disrupted microvasculature and impaired oxygen extraction. So we know now that for subtype of cyanotic CHD, severe form of CHD have a lower oxygen saturation in the umbilical vein, so at the start of the circulation, obviously. So if we push a little bit this idea, if we have an abnormal placenta, it's possible that it's not just the brain who is suffering, but probably the whole fetus. And that's a really interesting hypothesis, especially when we look at the result of this meta-analysis published in 2020. We show that SGA, small for gestational age, is 2 to 3 times more frequent in fetuses in CHD. So what is really important to understand SGA? Is it a potential marker of severity? Why? Because first, SGA alone increased the risk of neurodevelopmental disorders for baby without any defect. And actually, the results published by Epicard team and Joanna about neurodevelopmental disorder at 3 years of age show that SGA was the main risk factor with operated CHD, with 14 points in multi-level regression model, which is really nearly a full standard deviation, a huge effect size at the population level. And so we try to understand the mechanism involved. We can make the hypothesis that SGA is an indirect marker of the brain-sparing failure. So when we look at other studies, we can ever wonder if maternal stress, when we look at this kind of study, we can see that there is new core variable in the model. We know now that maternal stress can create some disorganization in the brain of fetuses. Fetuses with any congenital, without any congenital heart defect. So when you look at this study who compared pregnant women with healthy fetus to pregnant women with fetus with THD, first of all, you can see that the level of stress, anxiety, and depression in this subpopulation of women is much higher than pregnant women without fetus with THD. And what's really interesting in this study is that they made MRI for all fetuses, and they demonstrate that there is brain injury, especially in cerebellum and hippocampi, for this subgroup. So we can have the hypothesis between this anxiety, this maternal anxiety, and we can say that maybe it's a risk factor, maybe there is an interaction effect between the underlying mechanism of CHD to the brain and this anxiety and stress before birth. So let's move on another categories of risk factor who happening during hospital period. This whole period in the hospital is full of events that can affect brain. I obviously can go over everything, but I'd like to focus on a few key points. And to stay in the topic of our meeting, I want to talk about another kind of variation. It's the variation over the time. In other words, are yesterday risk factor still relevant today? There is an example. 30 years ago, Bellinger and colleague in Boston showed that the greatest is the circulatory arrest, the worst is the developmental score. But 20 years later, we don't see the same result anymore in Goldberg or Fuller study. So why is that? We don't really know. Is it a question of heterogeneity of CHD? Is it a progress in neuromonitoring? We don't know. Now, if we look at anesthesia, because it's most of the time a question of surgery, but it is important to not forget our anesthesist colleague, especially with sevoflurane, who seems to be associated to lower neurodevelopmental scores. And this is not just a theory or confounding bias, because we know now that on animal study, especially with macaque, 5 hours of exposure to sevoflurane caused 30 times more neuronal cell deaths than in control. So that's definitely a line of research we need to follow. Now let's talk about what's happened after surgery. The whole post-operative management, we can talk about it all the day, each core variable, ECMO, infection, seizure, feeding, breastfeeding, etc., etc., etc. But when you study each core variable, you can probably find a lot of association. But nowadays, globally, when you look at the proxy of all these core variables, which is the length of ICU stay, we can see that there is not so much difference when you have a standard healthcare pathway. When you look at the 2 first or the 3 first quartile, but when you look at the last quartile, represent the worst healthcare pathway. These children have worst score. So probably that means that if the child has a standard hospital course, there's not so much variation in outcome, at least with the same CHD subtype. In other words, we don't have a room of improvement for these children. But as soon as the hospital gets complicated with multi-event instability, etc., stroke, then the risk of severe outcome goes up sharply. Now, let's talk about what happened after hospital discharge. I call this after the hospital just to make things clearer, but of course, other stages are connected. One thing is clear, social and economic factor play a huge role. They affect the child environment, access to care, probably even development, starting as early as before birth or maybe even around conception. This brings up to another dimension about variation, is the variation of external validity. Can we apply the result from one study to all countries and to all healthcare systems? For example, this is our experience in EPICARD. EPICARD, it's a population-based study conducted in Paris and its surrounding. We followed children with CHD up to 8 years of age. And we put some core variables, proxy of socioeconomic status, as a confounding variables. And as you can see, very high or high level of maternal education is associated with a greater score of IQ, almost one standard deviation for very, very high level, huge effect at the population level. We also look at other indicators, like the language spoken at home or maternal origin. And children who don't speak French at home or with a mother of African origin scored lower, almost half of standard deviation. What does it mean? We need to be careful with the interpretation. Does it mean that ethnicity affects brain development? No. To understand this confounding bias, we need to look at other studies. This is an American study. Their observation is that there is a difference between a white American and Black American regarding IQ. And they want to explain this difference. So their first model to explain this difference, they put a lot of different covariable. I call this covariable during hospital covariable. Type of surgery, ventricle, abnormal imaging, history of seizure, etc., etc. They can explain just 1.6% of the model with all of this kind of variable. When they put income in the model, they can explain 70% of the model. And when you look at other subtests like word reading, they explain more than 90% of the model. So the most prevalent problem is income and probably access of healthcare. So to finish and to give it to you a more simple overview, I'd like to finish with the simple diagram based on EPICARD data. It focused on cyanotic heart defect with heart failure requiring neonatal surgery. In linear regression, we saw an average loss of 9.2 IQ point, which is about 2/3 of a standard deviation, quite significant. In this model, we identified intermediate variable, the green one, the hospital care pathway, neonatal distress, and small for gestational age. And we asked the question, INET versus occurred. How much does each of each core variables contribute to the final outcome? What we found is that neonatal care, including surgery, peri and post-operative, account for approximately 25% of the model. Birth distress, approximately 10% of the model. And SGA, 2% of the model. So more than half of the outcome is not explained by these known factors. Maybe it's due to INET mechanism or brain vulnerability starting early in fetal life, or maybe some of it's linked to social factor we can always measure now, like early access to care or even selective termination in some population. In any case, the question remains open. Thank you.